This conference will now be recorded.
Hello, everyone, and welcome to the AnCan High Risk Recurrent Advanced Prostate Cancer video chat for Monday, April 14th, 2025. I'm Lynn Sierra, and I'll be moderating today with a little help from my fellow moderators, Rick and Dr. John, and all of you, our well-informed attendees. And we want to acknowledge and thank our sponsors, and they are Bayer, J&J, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. And we have a shout out for a happy birthday to Alexa Jett, one of the most important key players in AnCan. I'm sure Rick would agree with that. So happy birthday, Alexa. If I could sing in tune, I would sing happy birthday, but I won't inflict you all with that. One other thing before I get started, but I think this is pretty important here. It's a breaking news category. I just noticed before I came online that JAMA in Internal Medicine published an article on the risk of CT scans on future cancers. Pretty shocking. Over 100,000 future cancers are likely to result from CT scans in a single year. Of 2023 was the year they were looking at. And although it's funny, they don't mention prostate cancer, but they do say that abdomen and pelvis CT exams were estimated to contribute the largest number of projected cancers, 40% in adults. So
can I comment on that,
please,
Len? Because I saw it too, and I found it a very puzzling article. Because what it said, and I'll find it in a second, what it said is that they found in 2023 that 93 million CT scans were conducted amongst 61 million people.
Right.
That's 1.5 million, 1.5 CTs roughly per person. Now, they also said that it wound up in 5% getting cancer, and that number they said was 105,000. But for the life of me, I can't figure out the math on that because it doesn't seem to make much sense. I had to write them. There were so many zeros. I had to write them down and make sure I was calculating it right. But if anybody can figure out the math, so I don't know how shocking it is until I can get somebody to look at it and tell me that the math is straight.
Yeah.
Well, Jim Marshall's our math expert. He could figure it out.
Whoa, that's below the belt. Oh, that's a bit below the belt. Oh, Captain, are you going to take that lying down, or are you sitting up?
He's taking it laughing.
Oh, good for him. But no, you know, I saw it too. I thought it was. It caught my eye, but I can't see how 105,000. How they get 105,000 diagnoses and how that represents 5%. And at one point they're saying it's over lifetime, and one point that it isn't over lifetime. So it was really confusing. But and there was also a editorial. So whilst Len's talking, I will post the editorial and the JAMA article in the chat window. How about that?
Good. Thank you, Rick. I also wonder how they can determine if these so-called future cancers were the result of a CT scan.
Right.
Oh, well.
Well, what they're saying is that CT scans are carcinogenic, and somewhere along the epidemiological line, they're figuring what these little radiation boogers, what percentage wind up in cancers. because
Yeah.
what they're saying is CT scans, because I saw that in there, are carcinogenic.
Ah.
Ah,
Well, that's bad news for me, who had 86 grays of radiation to my prostate and pelvis,
right.
which must be equal to 1,000 CT scans.
Well, that was exactly what went through my head. I mean,
Yeah.
we've all had so much radiation, and then they're telling us that CT scans. This is why I'm not sure I would leave it in the category of breaking news. It needs a little more explanation, as far as I'm concerned. Let's put it like that.
Yeah, I agree.
I expect it'll generate a lot of discussion in the literature because it sounds so alarming. So let's see what the professionals say, as well as us digging in a little deeper.
Yeah.
Yep.
I think yes.
All right,
I
well,
already put it in trash.
we
I'm
have
saving it. I'm pulling it out of trash because it's causing so much. JAMA Internal Medicine.
Yep.
I will say, whilst we're on that subject, and we have a little bit, we're not too busy tonight. There was a very interesting editorial from the editor-in-chief of the JAMA Health Forum. Very short, probably takes 90 seconds to read, about the atrocious state of the U.S. medical system right now, and I will be including it in the reminder for next week. In fact, I've already written the piece for the reminder.
Is that the one that they titled "The Terrible Moment in U.S. Health Medicine" or something like that?
Something like that. It wasn't exactly that, but it was. I sent it to you. Yeah, that's the one.
I think I saw it. Yeah.
And I'm going to post this CT stuff for you right now. I've got it halfway in. So,
okay.
but pay attention, because there may be some good things to listen to in the group. Don't be, Dr. Jim, Captain Jim. You can't do the math during the group,
Oh, Jim, you're tainted for the rest of your life. It's a shame. All right.
I wouldn't mind. Ben chose it as his editor's pick last week. If anybody noticed, he made Jim Marshall his editor's pick.
Yes.
Oh boy. The good men do is often turd with their bones, but the evil lives on forever, right? Okay, let's start with Don Rogers.
Yeah, hi guys. I watched the tape of last week's meeting. I wasn't here. Interesting, the discussion on testosterone coming back after ADT. I think I'm pretty atypical because my ADT, I took my last abiraterone on after I was on 2 years ADT, and the last abiraterone was June 1st, and I tapered off the prednisone after that. My testosterone is pretty remarkable, I think. It started in October 38.5, December 198, January 292, March 330, and just last week it was up to 423. So I think I should be pretty happy about that. The one side effect I'm experiencing, and that's why I wanted to mention it, is that I do have a lot of nipple tenderness for the first time ever. Is that normal? Is that something I should be concerned about? I'm just thrilled with my testosterone because I'm actually getting a libido back. I'm getting spontaneous erections. So life couldn't be better. And and I turn 73 next month.
Well, congratulations
I
on
have
that.
one question. I have one question, Don.
I know what it is.
How's your math?
I'm reading right from the paper. Okay, so yeah, the map is right.
So the nipple tenderness is something that could precede gynecomastia. If you're worried about it, maybe go see a radiation oncologist and see if he thinks you need a dose of radiation to the breast, or to see if if he thinks it's even necessary. I'll open it up to everybody else.
Well, estradiol is made out of testosterone, right? So you must not only be having your testosterone levels climbing, but your estrogen levels climbing, and that's probably what's responsible
Yeah,
for
the
this.
estradiol last month on March 20th was a 22.97. So you think that could be the cause of all this?
Sure.
They actually do an estradiol measurement.
Yes, right here. Yeah. Yeah.
I've never had that done. Anybody else have had that done or that test ordered?
No, I have.
Just routinely?
No, only when I asked for it.
Oh, okay. And who else had their hand up? David?
I had my hand up. I had
Did you
my
have
hand
to
up.
did you have to ask for it or they just do it?
I had to do it when I was developing gynecomastia from estradiol patches.
Okay.
They also did a mammogram at the same time.
So anyway, let's see. We've got Jack, your hand is up first. Go ahead.
Yeah, my hand was up, but John kind of said what I was going to say. Basically, he's had with this bounce of testosterone. Obviously, it's starting to synthesize the estrogen, the estradiol. Now he's up to 20, which is more than enough, more than most men have to begin with. And then he's having a reaction in his nipples. Doesn't mean he's going to get gynecomastia as much as the fact that he's getting, his testosterone and estrogen are going up at the same time. So he's synthesizing it, and it's going. I wouldn't jump into a radiation oncologist or a radiation consultation till I see, how it pans out over time, and see what happens first, and see, it's a good sign that you're having both go up at the same time.
All right, so where is my thinking wrong here, Jack, in that, and John? I thought that the estrogen can cause gynecomastia only if it's unopposed by testosterone. And obviously, he's got plenty of testosterone. So there's a lot of opposition there at the androgen receptor. So why would estrogen have that effect?
Because he hasn't had any estrogen in his body for so long that it's starting to secrete and it's starting to react in his body, and it's showing up in his nipples. And, we actually don't know how much testosterone he's got that's bound and how much is not bound. Older people have most of it is bound to globulins and albumin and very little free testosterone. So, but he's starting to get erections, so obviously he has some free testosterone going for him.
Thank you, Jack. Jerry Grimes, before I call on you, could you please mute because we're getting background noise, some conversation in the background there. I'll call on you in a minute. But first, we'll go to Larry in Alaska.
Well, in the patch study, they found that people on androgen deprivation using an LHRH agonist had a 40% incidence of gynecomastia. It could be that yours is showing up late. That would be a wild guess. My lab is telling me that normal levels for a man for estradiol is between 7.6 and 42 point something. So, if you have a lab test done and your estradiols are not outside that range, maybe what you're getting is a transient effect of the return of your testosterone. But it'd probably be worthwhile taking a full panel of hormone levels, finding your estradiol, estrone, and total estrogens, and have that looked at by an endocrinologist if you can get one.
Oh, I do have an endocrinologist. In fact, I see her again next week, and she ran about 35 blood tests on me. So, and they all look to be in the normal range.
Dr. John, it looks like that background noise is coming from you. Could you mute, please? Thank
Sorry.
you. Okay, now, where was I? Jerry Grimes, go ahead and unmute.
Okay. Yeah, no problem. Larry more or less said what I wanted to say, but I would add the blood test is called E2 for estradiol specifically. And I had some gyno that started after I ended my 3 years of Lupron. My testosterone came back pretty fast. I was up well into normal within 4 months or so. And I think my body had been without testosterone so long, I didn't know what to do with it, and it was creating a lot of estradiol as a result. After I came off of Lupron, it was a surprise to me because nobody had even suggested that could happen, but it did. So otherwise, as Larry mentioned, a transient effect of coming off of testosterone, suppression is a very good possibility.
All right, thank you, Jerry. And Gary Peters, go ahead.
I've been getting regular, like every 6 months, estradiol tests since I've been on patches to serve as transdermal replacement. And then I wanted to get to something that Jack mentioned about free testosterone. I mentioned last week that my testosterone was starting to show some life, but my free testosterone is still like nothing. And it's the free testosterone that's more clinically relevant, right?
Yes, if testosterone is bound to a transport globulin, it can't interact with the receptor. So free testosterone is what actually can do the work.
Hey, thanks, John.
All right, any more discussion on Don's issue?
Well, we really haven't answered your question, Len, and I don't know the answer, but maybe when Don sees the endocrinologist, he can find out. Like, how come you can have estrogenic effects in the presence of normal testosterone levels?
Yeah.
I think we should try to find that out.
Okay, Don, you got your marching orders.
Just a quick question for Don. Were you on Orgovix?
No, I was on Elgard.
Okay.
Elgard and abiraterone with prednisone.
Thank you.
Larry, go ahead.
Are you concerned about gynecomastia or the nipple sensitivity? Does it bother you?
Yeah. Oh, yeah. Believe me, I'll be pretty aggressive the next few days on this.
Yeah. Okay. I consider it a stigmata of the prostate cancer treatment.
A Jesus syndrome.
I'm going to get him tattooed. Blue ribbon.
Ouch.
All righty, guys, let's go to Ed Lefrancois.
Yes, well, just a little follow-up. I had a first month. Went well, nothing showed up. So that was all clear. And then I did meet with Dr. Kim from Yale Smilow, and he was quite nice. We had quite the conversation. He was very helpful. He asked us to get the Dceipher score. Then following that, we had the I had the testosterone at the same time, and it was 287, which that was the first time I ever had the testosterone checked. So from there, he set me up with Dr. Austin, which also works with him. But instead of me going out to New Haven, I'm just going to the Waterford, which is just 20 minutes from my home. And I'll be getting radiology in Waterford also. And I met with Dr. Aday, and that was a little tougher conversation getting him to do the Dceipher score. He said at MSK they do what is called an impact study. But we don't know if that'll turn up the same results as the Dceipher score, or are they both the same, or is there different?
Ed, what's your Gleason score?
Gleason score. Gleason score was a 3.
No. 4 plus 4.
It was a 4.
All right. So Dceipher doesn't really make sense for you because Dceipher is a test for guys with low or favorable intermediate, like 3 plus 4 cancer, to see how aggressive their cancer may become.
Okay.
So you're already in the high risk group with a Gleason 8. The impact study at was it Sloan Kettering, right?
Yes.
Dr. Aday? Yeah. So that's their gene sequencing database.
Yeah.
And so that makes more sense to me, what Dr. Aday is telling you. Anybody else want to chime in?
Yeah, a couple of things, Len. The Dceipher score was originally created for men post radical prostatectomy to see how likely their cancer would recur. Now, the Ed's situation is he was a 4 plus 4, but his post-operative pathology came back as 4 plus 3 and T3A. So he's actually a good candidate for a Dceipher score. There's no reason why you cannot ask. You can tell Dr. Aday that that's what you need, and if he's not willing to do it, have your pathology sent to Yale and ask Yale to send it off for a Dceipher score.
Okay.
So, it's usually the thing is with Dceipher, a lot of people now use it pre-radical prostatectomy, but that was never the real intent. The intent originally was to see whether you need more treatment after your surgery. And I think, and Dr. John, correct me, but I think it doesn't it go up to like 100, and the score is like, if 80 is very high, or am I off by?
Goes from 0 to 1.
0 to 1. Okay.
So 0.8 is what you were thinking of, an 80. You've got the You've got the Marshall syndrome with the decimal point.
I got the decimal point is that Marshall syndrome. Yes.
Get Marshall, go get him.
The Marshall syndrome.
That's right. The problem with these tests, and I'm not very good on them, is that they all measure in different units. So one goes up to 100 and one goes up to 1, and so you're never quite sure where they are. But I do think that it is a good suggestion, because it'll give you an idea of the aggression. There's nothing wrong with doing that impact score, but it's not, even if it comes back and tells you what they find, it may not be helpful. On the other hand, if they were to find somatic P10 or somatic TP53 or something like that, that would tell you a lot. So, let them go ahead and do it. But I would also go ahead and do the Dceipher score if it were me.
Okay.
You already know Ed has an ATM, right?
Yes.
Oh, that's right. He has an ATM. Thank you. Yeah. He has an ATM. So.
Hi, Lisa.
And what treatment have you had so far, Ed?
I haven't had any yet. Next week we're meeting with Dr. Austin, the the GU medical oncologist, and then 2 weeks after that we meet with Dr. Patel, the radiologist, and we'll see what they their plan is for me for the next.
All right. Okay, so the Dceipher makes more sense then.
Yeah, I just have to add one thing. We had off for having the impact tests done. So we can still ask for the Dceipher just as well.
I couldn't get that. Anybody? Rick, did you hear that?
Sorry. Huh.
Did you say, can you ask for the Dceipher as well as the impact?
Yes. Yeah.
Yeah, there should be no shortage of tissue after an RRP. I mean, given that he had a radical prostatectomy, there should be no shortage of tissue for them to run a couple of those tests. They may tell you got to wait until the impact study comes back.
Yeah.
That I don't know. And the problem with the impact study is it takes forever. That's one of the disadvantages of doing it. They take like 4 to 6 weeks. Why? I couldn't tell you. That's why we advise people not to bother with the impact, to go to, if you're going to get a sequencing, go to Foundation Medicine or Tempus or somebody like that, where they take 2 weeks. But I mean, to me, you're as I overlooked it. It's right here, but we know your ATM, and I'm trying your ATM germline. I'm trying to remember. Just raise that with Patel. Anybody remember if ATM germline has an impact on radiation? No, it's good news if you're getting Pluvicto, but thank goodness you're not getting Pluvicto, because we know Pluvicto performs better in the face of ATM. I can't remember if it has any impact, but it is worth raising. It's worth raising it as a question.
Okay.
We would have to ask Dr. Aday, who is the surgeon, and we did speak to him last Thursday. He wasn't keen on allowing the Dceipher for some reason. He just was.
Well, did you tell him Did you tell him that the Yale guys wanted to do it?
No.
Okay. Did he ask you why you wanted it?
Yeah, he sort of. He just went around. We just asked if we should. We thought we should have the Dceipher score, so that would lead the treatment that's coming forward. And he went around talking about the company for about 10 minutes, the Dceipher company, and in the end, he ended up looking back at Ed's pathology, post-surgical pathology, and then he said, I think what you're talking about is we can do this impact study here at MSK. So he leaned toward that.
Yeah, it's not really. I mean, I understand why Dr. Kim asked for it, and it's really for something different. And did you indicate where you were going to get the follow-up treatment?
No.
And did he indicate what he wanted to do in follow-up treatment?
Well, they already had set me up with an appointment with a radiologist down at MSK.
Okay. So, I think he's sort of saying, well, what do we need this for? Because we've already made the decisions. And so, what I would say is, if you're going to move forward at Smilow, ask them to send your tissue to Kim or whoever it is, and then have Kim do it.
Okay.
Okay.
Until you can tell Kim, Dr. Aday didn't want to do it. I'm going to ask for them to send the tissue to you, and please could you order it since you feel it significant.
Okay.
Do you agree, the fellow mods, Len and Dr. John or anybody else? Do you agree?
Sure. I mean, it can hurt. I'm not sure it's the Dceipher is really necessary. What is he, 4+3, you said, Rick?
Yeah.
Yeah.
Okay, so I thought that if you had a 4 number in there, it's pretty clear that you have potential for aggressive spreading prostate cancer.
Well, not really, Len, because if you think about it, Dceipher was originally it was originally developed for people who had low intermediate and high intermediate disease, where they were uncertain, because not everybody with 4+3 or 3+4 does go on. It depends, whether there are margin issues. It depends what they find in the pathology. So that was why they developed that test. They didn't develop it as a test pre-treatment originally, and they developed it to see whether you needed additional radiation or not. And so the question is, do you need additional radiation? Well, since Ed's 4+3, but T3A, he definitely needs it. But again, the other reason is to go back to Kim and ask him why he thinks he needs it. Len has a decent point. If you were 4+3, but you weren't T3A, it might be more important. But you're T3A, so we know you need some follow-up. So you could ask him why before you twist yourself into a pretzel to get the tissue to him. I mean, you can ask him. It's a reasonable question.
Yeah. All right.
Didn't the second biopsy have intraductal and cribriform pathology? So in that case, what happened to the pathology report after the prostatectomy? Did that also report cribriform and intraductal pathology?
Yes.
Okay.
Same.
So we lean toward being aggressive in that case.
Okay. All right.
That's like having a 5 in your Gleason. Yeah. Also, the Dceipher scores for figuring out whether you're likely to have metastasis soon, or whether the cancer is going to come back soon. That's one of the main reasons people are getting it, to find out the likelihood that, because if you're for 4+3, but you end up with a 0.2, you're not likely to have metastasis soon. So it's though I've run into 3 people, 0.98, 0.99, and 1.0 in the last 2 months. It's you never know.
Soon being defined as 5 years for Dceipher, isn't that right? Jeff, you were saying
No, I'm not sure about the number of years, but it was just the likelihood of either the metastasis or reoccurrence would occur soon.
I think it was 5 years.
5 years, okay.
Ed, what have you had another PSA test since the 0.22?
Yeah, they did that along with the testosterone. It was 0.235.
Okay, well, that's good news. So it seems to have stabilized a little bit.
Yeah.
Yeah.
And are they going? And you had a PSMA CT scan set. Did you do that?
Yes, we did that at the beginning of the month, and that was all clear.
And it was all clear. Okay, great.
And I'm glad he's always had fairly low PSA numbers. You had asked us originally, even prior to the first biopsy. We did look that up since the last time we were on.
Yeah.
The highest it ever was 3.07.
And that was after his first biopsy, but before anything, like right before the biopsy was 1.44. It came back.
Yeah, I mean, that's really helpful. It's something that you need to be stressing with all your doctors.
Yeah.
Because if if it turned out that you were either a 4+4 or a 4+3, and you've got cribriform and introductional, and you only ever made the most PSA you ever made is 3.07, they do need to factor that into whatever decisions they're making.
Yeah, that's good information. Thank you for that. Yeah.
John, do you have a comment on that?
Sorry, I was typing some of his information into LGL. What was the question, Rick?
Just the fact that the highest his PSA ever was 3.07.
Yeah, he never got much PSA, so it's probably going to be a poor biomarker for progress.
All right. Well, it'll be interesting to see if you do have the Dceipher test, what the score is.
Right.
Yep.
Right.
It's just information, I guess, can't hurt.
Right.
Okay. All right. Thank you.
Graham, you are up next.
Yeah, so I had the radical prostatectomy in December, and my the pathology of the prostatectomy was PT3BN1, and that was a 4 + 5 = 9. The PSA about 2 months out was around 9 point something, and it went to about 10.5 at around 3 to 4 months after. I had a PET done, and it showed a tiny bit in the one of the seminal vesicles, and near the bladder neck, and in the pelvic nodes. I'm undergoing radiation for the prostate bed area and the pelvic nodes, and also they did radiation on my rib. I just finished the radiation on the rib, and now the doctor is talking about going on. Well, actually, I'm taking. It's Orgovex, and he's saying once I'm done the radiation, he's recommending that I do abiraterone with prednisone, and so at my stage is he's recommending it. Is that kind of like a normal course of action?
Well, it's certainly one option. You do have metastatic disease, and it requires, at the minimum, a doublet therapy of ADT plus abiraterone or some receptor blocker. So I think it's appropriate.
Okay.
Yeah, guys, anybody want to chime in?
I suppose technically it's still low volume disease, and it's still a little vague who gets triplet therapy, I know, but there's no reason to push him into docetaxel, is there? How many, you have one lymph node and then you have one bony metastasis, did you say?
He said there were a number of areas within the lymph nodes that were kind of showed up positive in that PET.
But you mentioned a rib also, didn't you?
Yeah, the rib. Yeah, one rib metastasis. That was it, and I've had 3 rib treatments of radiation on that.
So I'd probably ask the doctor I agree with adding the abiraterone, and I would even ask if you might benefit from a third drug,
Yeah, what would you think would that be?
acetaxel,
How do you spell that?
DOCITAXEL.
DOCETAXEL.
Oh, sorry, DOCE. I was just going over what
It's the
the
most common chemotherapy drug used for prostate cancer, Graham.
Okay.
So
Yeah, I wrote
Graham,
it. Yep, go
Graham,
ahead.
let us just explain, because we're throwing around terms like docetaxel, and that can be kind of scary. So for somebody like yourself, let me just recap. You had a radical prostatectomy. You said in December, is that right?
Yeah, December the 4th.
Okay. And where did you finish up doing that?
I'm in Canada.
Okay, so this all happens in Canada. Okay.
Yeah.
Now, and that was a robotic.
Oh, he did open.
He did open. Okay, so you did an open RP. Okay. Now,
So I had a hernia at the same time, so he needed to, in order, because of the radiation, they needed to get the hernia out of the way. He wanted to do open.
okay, no problem. So you did an open RP in December of 24. Now, you said that. Did you say your PSA rose to 10.5?
And about just before I started the radiation treatment, I suppose. Yeah, I'm about 2 weeks into the radiation.
So like the beginning or the end of March, the beginning of the beginning of April, your PSA was up to 10.5.
Yeah.
And they did a PSMA. Now, the protocol, and let me just also, for your benefit, and maybe somebody can put these in the chat window for you. The androgen deprivation drug that you're on is called Relugolix, which is the same as Orgovix. The secondary ARSI, the secondary drug, is abiraterone acetate with prednisone. So those are the drugs you're on.
Well, I take the abiraterone after the radiation is finished. He wanted to wait for that to be done.
Okay, good. That's what he's going to put you on, and we can talk to you quite a bit about abiraterone and how you're going to take it, because there's different options, but he's going to put you on. Now, the protocol says if you have less than 5 spots that we can see from the PSMA in your case, because they did a PSMA, then, and some people say less than 4 spots, then you should just be on 2 drugs. If you have more than 4 or maybe 5 spots, you should talk to the doc about being on 3 drugs, one of which is a chemotherapy drug. So what you've really got to tie down is how many spots did you have? He said multiple spots. Do you have a copy of that PSMA report?
I can get it. I did it privately.
Okay, you need to get that report, and you need to see exactly how many. You know, that there is again some dispute. If you had a bunch of pelvic nodes that were all in roughly the same place, some people think, well, that's really a 1. But if you've got pelvic nodes all across the pelvis in different places, it might be more than a 1. We know you've got bladder neck issues, and we know that you've got a rib. We know that there was disease in the seminal vesicles. So we've got to do is find out exactly how much cancer did you have, because that dictates exactly what surgery you should get. Now, the fact that it's in the bladder neck probably means you want to be a little bit more aggressive, because if it's in the bladder neck, it can easily have gotten out the bladder neck. So we've got to, it would be, if you were wavering on whether to get chemo, we would probably say get a second opinion, if necessary, even in the United States, and get a second opinion from a genitourinary medical oncologist and see if they would recommend you getting the chemo. It's not going to be difficult for you to get the chemo in Canada. That's the good news. And you won't have to get it privately. But you also have to be coordinating your national insurance with your private care. And I don't know how tricky that is.
How long would you be on chemo for?
Well, I'm just picking a number. I'm not saying this is you, but I'm just picking a number. Let's say you had 10 different spots. Then the chemo that would be recommended, the protocol that's recommended, is 6 sessions, 3 weeks apart. That's what's recommended. Every 3 weeks, chemo every 3 weeks, and six sessions. Doesn't mean to say you have to do all 6 sessions, but that's the standard protocol for somebody doing chemo in that situation.
And there's an alternative to abiraterone, is there, if you can't tolerate it?
It's abiraterone is the name of the drug. Again, if somebody could put that in, please, in the chat window, abiraterone acetate. There are other alternatives, but the consensus is that that's probably the best one to start off with. There, Jim Marshall's put it in. Thank you, Jim. And you take it with prednisone, and John put it in. Thank you very much. And the other drug that you're on is the province paying for your Relugolix, or are you having to pay for that privately?
Because I don't have insurance until 65, the drug company's covering it.
Oh, okay, that's good. That's good. Well done to your doc for getting them to do that. But that's basically a regular androgen deprivation therapy. It's a better drug than the other drugs, but you can start. How long have you been taking it?
Oh, for about 3 weeks now.
So it's going to start. Are you experiencing any side effects as yet?
Not really.
It'll start catching up with you relatively soon.
Okay.
Did you check did they check your testosterone level before you started the drug?
I don't think so. Just the total testosterone I have.
Yeah. Do you know what your total testosterone was before you started the drug?
It was in the normal range. It's something like 18.5, maybe. Whatever they measure it in.
Yeah, we have to.
19.7 AMOL over L.
Okay, so somebody can run a quick translation to put it into US numbers for 19.7.
I nominate Jim. Sorry, Jim.
Oh boy.
I don't speak Canadian.
Come on, guys. Somebody there can pull it up on the computer. You just have to get testosterone conversion chart. Testosterone conversion chart and put in 19.7 and it'll tell you what that is in the numbers that we know pretty well.
All I can say is they show a chart and it shows up in the upper normal range. So
okay, it's probably about 400 or 500 or something like that. I just actually found this chart for somebody in Europe a couple of days ago, and I know I bookmarked it, but trying to make someone else do a little work here.
Yeah, you end up with hundreds of bookmarks. So
yeah, I can probably find it pretty quickly. So I just wanted to make this clearer for you because, you know, it's not just going in and talking to the doc about a third drug. It's a very serious third drug and it may be appropriate, but it may not be appropriate either. And what normally will dictate it is how many different sites of metastasis you have.
okay. And the abiraterone and the Orgovyx, he's suggesting 2 years, but I mean, does that mean actually indefinitely?
That's a really good question. I actually, if you got our reminder last week, I actually referenced an article on that. I think that, again, we're not giving medical advice here. I think the consensus is probably that you can jump in and do a certain amount of time and which would be at least 18 months, somewhere between 18 months and 36 months. And then you can see where you are. But there are schools of thought that you never come off. Now, we are only advocates and we see a lot of things and we talk to a lot of people and we read a lot of stuff. But if it were me, I would not be looking at being on indefinitely on this type of salvage adjuvant therapy. But let me throw this one over. I know Len has some opinions on it too. And it's a great discussion. It's a great question. I'd be interested to hear what other people have to say, and it could be very educational for you. Go ahead, Len.
Rick, I was busy finding the testosterone nanogram to millimole conversion, which I posted in the chat. So I did not catch your interesting question for Graham. Sorry.
So Graham says the doctor's telling him that he's going to be on treatment with this treatment. And let me ask you, what are they talking to you about in terms of radiation, other than the spot radiation to the rib?
Well, I'm doing to the prostate bed and the area around there. I'm doing 20 sessions.
Okay. So you're doing 20 sessions. So
the doctor said that everything in that area is treatable with radiation. He felt.
Yeah. So there's another issue here as well, which is whether they're going to radiate the whole of across the pelvic girdle, or whether they're just going to radiate the pelvic bed. What type of radiation? And this is something, again, that you may want to get more than one opinion of. There are doctors who are more aggressive in the United States who radiate a wider area.
My understanding is that they're doing the general area, and then with the PET scan, they're overlaying that and my CT imaging, and they're targeting with in a more specifically the spots that come up positive. So it's
Okay.
it sounds like everything, and then the positive areas really zap them more or longer.
Okay, but does that mean that they're just going to radiate the pelvic bed and around the pelvic bed, or are they going to radiate from one side of your hips to the other side of your hips and do those other areas specifically?
Yeah,
it's a very, very important question.
Yeah, I don't know.
Right. So you got, when you say, well, my general impression is they're going to radiate the general area, that's what we're trying to focus you on to ask that question.
Okay.
There are doctors in the United States who would be more aggressive, would radiate right across your pelvic girdle, and say, yes, there may be a little bit more risk of side effects, but this is probably the safer way to go. And there are other doctors who would say, no, we're just going to radiate the prostate bed and any specific spots that we see. And what you've got to determine is which way you want to go. And you may come across a doc who is not so aggressive, but our concern has been that in talking to some of those doctors who are less aggressive with the salvage radiation, those are the guys where the disease has come back. So do you want to really hit it hard? Who would like to discuss this? Who has the experience, and who would want to discuss this with Graham?
So it sounds to me like you said you had pelvic lymph nodes lighting up, right, Graham?
Yeah.
Yeah, so you definitely need radiation to the prostate and the whole pelvic region.
Well, I know they're doing more than the where it lit up.
Yeah, so, right. That's what I'm saying. They'll do the entire pelvic region. Maybe they'll concentrate on the identifiable lymph nodes that are positive, but they'll, there could be micrometastases and other lymph nodes in your pelvis, and they'll want to hit the whole thing. The only question is 20 sessions. I guess that would be hypofractionated IMRT, because to do the prostate bed and the whole pelvic region is typically more than just 20.
Well, we don't know. That's
number, isn't it?
It was 3 passes of the machine that did me.
You've already had this done?
I'm partway through it.
Partway, okay.
Yeah, I got people who do the prostate only do maybe like 1 pass of the machine, and then talking to someone who's doing it, they're saying because you have these other areas that lit up, it does 3 passes.
But that's not 20 sessions, and I think
that's in 1 session. Yeah.
Right. But we're talking about 20 sessions, and we're also talking about spot radiation to the rib. So I think that you have got to find out exactly what they're doing.
Okay.
Like I'm saying, you've got to find out what that PSMA report says. You can't necessarily rely, and you don't even know that they're going to tell you what they may be telling you, what they want you to know. You've got to find out exactly what they're doing and how many sessions. The question is, how many sessions of IMRT? They can't be saying, well, it's 1, but it's really 3. No, how many sessions of IMRT, or if this were IMRT, how many sessions would it be? Because I agree with Len and Dr. Jones that if it were only the equivalent of 20 sessions of IMRT, then it's not really enough.
Okay, well, they definitely scheduled me for 20.
They're using EBRT in Canada now, which uses fewer treatments, and it's the new EBRT is a much higher.
We don't know, Jeff. We don't know.
I've run into other Canadians that have been saying they've been using EBRT up there.
I don't think he knows. This is the problem. This is the problem we're running into. We don't know if it's IMRT, EBRT, whether it's hypofractionated. We don't know. And this is why we're encouraging Graham to nail this down, come back next week, and we can help guide you to make sure that you're getting what would be standard down here, and and help you determine.
Have another session next week?
But will you see the doctor or just the
No,
technician?
no, for AnCan.
Oh yeah, we have sessions every week for the first 4 weeks of the month.
Okay. Is that on a Tuesday?
Next week it's on a Tuesday. Yeah. Are you receiving our
Email? Yeah. Okay.
You are. Okay, so just watch the emails. It'll tell you it's either a Monday or a Tuesday. Next week it'll be on the 22nd at 5 o'clock Central. You're on Central Time?
Eastern.
Okay, 6 o'clock Eastern.
Okay. Thank
you. Anybody else want to comment on the question that Graham posed, which is, am I going to be on hormone therapy for life, or am I going to be on for a limited period of time?
This is the perennial dilemma: continuous ADT or intermittent ADT. What I'm concerned about is why he wants to wait till your radiation is finished to begin the hormone therapy, when it's pretty well established that when you do them at the same time, the results are better.
I'm doing the Orcovix, but the other one, he wanted to wait because he said he didn't want to pile things on. That's what he said.
Okay, well, I'm not sure if the recommendation for concurrent hormonal therapy is sufficient with ADT, or is it sufficient only with both? I don't know. Anybody, Rick or John, you know the answer to that one?
Well, I know when I was in a similar situation, I said basically pile it on. I'm not too worried about it being piled on too much.
Yeah.
I mean, we're not oncologists, but we are used to treating situations like this aggressively, and that means at least 2 drugs. And it's not like the side effects of the abiraterone plus the side effects of the radiation would be terrible. I was once on those 2 things at the same time. They're really different kind of side effects, so I don't think that it would be too rough on you to do both at once.
Yeah, I'd agree with that.
Has anybody in this session here today done salvage, or let's call it salvage radiation, with a ADT and an ARSI, with the 2 different drugs? John has. Anyone else done salvage with both? And Don Rogers has. I think if it were in this country, we'd be seeing you getting both those drugs right now.
Yeah.
How long were you on the ADT before they started the radiation?
2 weeks.
A couple of weeks or so. 3 weeks.
Again, I think in this country they'd put you on, they'd leave you on for about 6 weeks.
Yeah.
They'd leave you on the Relugolix and abiraterone for about 6 weeks, and then they'd start the radiation. Because there's another school of thought that it weakens the cancer cells if they've been exposed to hormone therapy for a period of time. So I'm not sure it would be done this way unless it was in a maybe in a community practice where the knowledge wasn't there.
Jeff,
You know, I would imagine that one reason they held off the abiraterone is because it causes so much fatigue for a lot of people, and so does radiation. So maybe you didn't want to hit them at once. But usually, I mean, I've seen so many cases where people have been getting the radiation 3 months of, the ADT and ARSI 3 months ahead of time. And I've actually seen numbers where the metastases have shrunken over that time, and that made it easier to do the radiation. But 3 months is where what a lot of the doctors I've seen in other reports talking about doing it ahead of time. So 2 weeks is like doing not at all for a few weeks.
You know, the problem, Jeff, and you, as you know, because you've helped people in Canada, is to some extent you have your hands tied behind your back because you don't have the control over with the doctors that you want. If you're going through the state, is your hormone therapy going through the state?
Yeah, that's exactly it. You don't have the ability to reach out and contact the doctors and get the appointments as quickly.
Right.
And yeah,
right. It's a real problem. But what you can do, and we've seen it done, is you can start governing. You can say to them, "I'm not doing any more radiation until I've been on hormone therapy for 2 months. I'm stopping. Hold on for the horses. I need to be on this for 2 more months." You can do that. We've seen guys do that. The docs don't like it because they don't want to be told by the patients what to do. But the fact is, they're not following the protocols. But it depends how assertive you want to be. And you can say to the doc, "I'd like to start my abiraterone right now." He may say, "No, I'm not willing to start it right now," because he's got cost constraints on him.
yeah, there's no cost constraints on that.
Well, there may be when he starts it, and I mean, it's available to you, but he may have constraints on when he's supposed to start it. He may be measured. I don't know. There shouldn't be. You're right, Graham. There shouldn't be. But if not, you say to him, "No, I don't want to do it, and I want to get onto this abiraterone." And if he says why, you say, "Well, that's the protocol."
Any other questions for us, Graham?
I don't think so. I'd like to thank you all.
Well, thank you. And come back next week and let us know if anything changed. Next is
Graham, you're in the driver's seat. Take it.
Yep. Dan, Alexandria.
Oh,
Go ahead.
great. Hi, guys. I got a second opinion on that recent MRI from another radiologist on my hip groin area. And he was certainly aware of my low PSA levels, 0.01. He agrees with the original report and indicates that findings are concerning for aggressive marrow, replacing such and actually having metastatic disease. And his recommendations are 3: either a PSMA PET scan, an updated NM bone scan, which is a nuclear medicine bone scan, or a CT guided bone biopsy. My questions to everybody here would be, since my PSMA would not record anything since my PSA is so low, and it also might even record inflammation from the arthritis, is it even worth considering the PSMA? Dr. John said it might be. And would a nuclear medicine bone scan be better to do this, or should I just push for the CT-guided bone biopsy, even though it's going to be painful? And in terms of that last option, today my rheumatologist said because of the location of this, it's going to be really, really difficult to do any biopsy in that area. And if the biopsy comes back as positive, it's going to be really, really difficult to do radiation in that area. So maybe in my mind, it might be better just to do active surveillance, but that's as much as I have today.
Well, Dan, I would say if by nuclear medicine bone scan, I think you're talking about an F18 PET scan, which looks at the bone, and it's not very sensitive. Some radiologists refuse to even do that test anymore because, I mean, if we're worried about PSMA not picking up anything, certainly the F18 PET bone scan is not going to pick up anything. It's far less.
I fully agree. And last week I reported that it's not worth doing a bone scan, a typical one. But he's mentioned it in nuclear medicine, and he's probably thinking technetium 99.
Yeah, technetium. That's just as bad.
That's even worse. That's even older technology than the F18.
Yeah.
So again, they love to bamboozle you with a nuclear medicine. Yeah.
Right.
That's old medicine, doc. What about new medicine? What is your latest PSA?
0.01.
0.01. 0.01.
Correct.
I mean, I would say if it were me at 0.01, it's a PSMA is not really going to show anything. What was your PSA before you went into treatment? It was as high as 14.1 at one point, correct?
Yeah, almost 15.
Yeah. So I would say if it were me, I wouldn't bother with a PSMA scan.
Right.
The problem is that unless you come off, which you can do and guys have done, unless you come off of your drugs and force your PSA up, it's not going to recover for a heck of a long time because your treatment is whatever you're on, Zoladex and Eligard for the next 2 years, right? A year and a half.
I'm just on Eligard right now. Lupron.
You're just on Lupron. Didn't you do abiraterone at some point?
Yeah, and because of the impact of prednisone on my real weak bones, which they never did a bone scan until this past 4 months, the oncologist realized the impact of that, so she has me off abiraterone and prednisone.
Okay, well, why doesn't she put you on a different ARSI?
I asked her last month, and she said they're all going to have the same side effects. I think she's stonewalling.
Yeah, I think she's stonewalling too. I mean, you tell her that it's again protocol, and yeah, if you can't be on the abiraterone, you could be on another second line anti-androgen.
Darolutamide.
And if she doesn't, if she continues to stonewall, you got to try and get yourself to a doc outside of the Kaiser system. This is Kaiser.
Right. The other thing I learned from the rheumatologist, she explained that I'm not getting pain from the osteoporosis. I'm getting pain from the arthritis. And she's indicated you just take an extra pill, a leave or whatever. She's concerned that it might be more serious as a progression of the cancer. And that's why these 3 options are there.
Yeah, but they're not going to, I mean, I don't know what they're going to get. I mean, the best one for me would be a CT guided butt biopsy. Let's worry about how we treat it. Let's do, if it were me, I'd do the CT guided biopsy because that's definitive. Go after the spot where they see a spot, do it, and then let's worry about how we treat it when we know what's there. If there's nothing there, there's nothing to treat there.
That's where I'm leaning, but what she indicated today was because it's at that juncture of the groin where all your muscles and veins go through, it's going to be really tough to do a biopsy there. And down the road, if there is anything, it's going to be really tough to do radiation. But that's for them to work out.
Forget about down the road, okay? Forget about down the road. The first question is, who offered you the CT guided biopsy?
The second radiologist.
Okay, then go back to the second radiologist and say, yes, I'd like to do a CT guided biopsy.
Mm-hmm.
Because otherwise they're bouncing you all between them, right?
Right.
Dan,
this one says, yeah, you can have a CT guided biopsy. Go ahead, Len.
Do you know specifically which bone it was, like iliac or pubic?
No, I don't.
Okay. Because I had an iliac bone biopsy. Wasn't particularly painful.
Oh. What was the other one, the pelvic?
Well, the iliac is your pelvic bone. Mine was superior iliac, which is the whoop. Sorry, I think my connection kind of weakened there. Can you hear me?
All of us, I think.
Yeah, you're back.
Glenn.
Oh, it's all of us? Okay.
Everybody got hit.
Yeah. So there was no problem for me if the superior iliac. Now, I don't know if it's your pubic bone, which sounds more like it might be since you mentioned the groin. I've never had a biopsy there, so I don't know. I don't know if Jack or John might have any opinions on that.
Yeah, but
well, the superior iliac spine is the easiest place of all to take a biopsy.
And the pubic
You
bone
don't
is
get the
easy
best
to,
spot. If it's down in the ischium, where that will be really tricky. If it's in the pubic bone, I don't see why it should be all that
guys,
difficult.
I don't think we should be speculating. We don't know. We can't be speculating on this. I think what we've got to do is if it was offered, say yes, that's what I'd like to do. Otherwise, with too many ifs, ands, or buts, we don't know. If it was offered, let me ask the Brains Trust here. Which of these three options would you go for?
Well, I've been interested to listen to this conversation because I've already put my 2 cents in, which is that a difficult bone biopsy in apparently a difficult place is invasive, intrusive, and you don't do that if you can get away with a less invasive diagnostic procedure. A PSMA PET scan is less invasive, but also has less chance of finding anything because of reasons that we've already discussed. So what I said is that if the PSA PET scan comes back positive, you've got your answer. It's a metastasis. If it comes back negative, you disregard that result. It's a meaningless result. It doesn't mean there's no cancer there. And then you have to proceed to your biopsy.
Yeah, but John, would you go through a PSMA PET scan of 0.01?
Well, what's go through? It's not anything really to go through, just an injection.
Well, yeah, it is and it isn't. I mean, why are we doing a test for 0.01 when we're almost... It's highly, highly unlikely it's going to give us a result. I mean, to me, and we have to be respectful. We have to be respectful of the medical systems, even if it's Kaiser. And if it was 0.1, I would say yes. If it's 0.01, I don't see, yes, it's better for the patient if it showed something, but the likelihood that a 0.01 PET scan is going to show something is slim to none. So I wouldn't be advocating to a patient, navigating a patient to get a PSMA scan at 0.01. I could be wrong, but I don't see the point. Same thing with the bone scan. I mean, the bone scan just doesn't show anything. If we really want to know, the most unpleasant of the lot is to do the biopsy, although it can be done, as somebody put in the chat window, it can be done under anesthetic, and at least we have a definitive result.
Hello, everyone. This is Henry. I'm listening to the
Hello,
conversation.
Henry.
I'm kind of baffled. I'm kind of surprised that they would even do a PSMA with such a low reading, because I've been battling with my doctors for a while, and my reading is 0.01 to 0.1, and they say a PSMA will not even pick anything up.
Yeah, I agree with you, Henry. And to be honest, I'm kind of shocked that Kaiser would even suggest a PSMA scan at 0.01.
Dan, what about MRI? Did anybody ever suggest an MRI to help distinguish, some sort of arthritic condition from a cancer lesion?
Already done.
Right. Great question, Len. That's why we're at this juncture. The MRI was done a month and a half ago, and the first radiologist indicated approximately the same three options without the biopsy.
So the MRI was not helpful.
It was not helpful at all. It was essentially saying it could be metastasis, or it could be a involuntary fracture, I think was the term. Dr. John, was that the right term?
They did use an odd term, not a pathological fracture, but
insufficiency, was it?
Insufficient fracture.
Insufficiency fracture.
Right. Thanks, guys. I hear everything.
Sometimes there's not a clear answer.
Exactly. And sometimes the more painful one, even though Dr. John is right, maybe we take the conservative thing if we're all doctors, but sometimes it's better just to go for the jugular and do the more painful thing, as Rick is saying, which is going to give a result, even though it's going to be hard to get in there in that particular juncture of the body. Thank you.
All right, thanks, Dan. Dr. Jack, you are up.
Okay, so I just wanted to ask a question to you old pros, since you've been in the trenches so long. And my question has to 3.5 weeks I've been on my holiday from doublet therapy after not quite 2 years, 23 months of darolutamide and 21 months of Orgovyx. And I've had something happen to me that I didn't expect. I've had more hot flashes and night sweats than I ever had when I was on the ADT and the darolutamide. And I'm trying to figure out, teleologically, medically reasoning, but I haven't come up with a good answer. What exactly is causing me to break out with so many hot flashes and night sweats? Very uncomfortable, and none of which happened. Well, I had them to a great degree, but nowhere as much as I'm having right now. In your experience, anybody taking a holiday and had more night sweats and more hot flashes after taking a holiday? And if so, did it go away? Did it get worse? Did it get better? What happened?
Well, Jack, what's your T level?
Oh, I don't know. I haven't seen my medical oncologist. I'll see him sometime in the end of May. I'll get a T level then, and I'll get a PSA. But I don't know. 3.5 weeks, unless I'm having some kind of a bounce. Since my 2 years ago, my testosterone was 740, and it's possible being on Orgovyx, it may be temporarily bouncing up, and maybe there's some thermoregulatory issue going on with my pituitary because of something having to do with that more than I don't understand exactly. That's why I'm asking you guys.
Yeah, anybody meet those criteria can help Jack? Jim Marshall?
Yeah. Let's see. I stopped things back in 2022 June, and I continued to have the flashes all the way through. And in fact, last night I did have one, so I happened to turn on the fan and I brought up the blankets. So it's something that occurs.
You continue to have them, but did you have more than you had prior after you stopped it?
They have tapered off essentially over time. But it's been like close to 3 years now. So.
Oh, well. Anybody recall what it was like a month after?
Yeah, a month afterwards, it didn't change. It didn't change for almost even a year. Of course, I was on it for 5 years. So.
So Rick and then Jeff Markey.
So, Dr. Jack, what I'm thinking is that, first of all, you were on Orgovyx, Relugolix. So, one thing we do know is that the pituitary and the testes come back into action much quicker. And also, anything else they were suppressing. So, whatever makes the estrogen, and I don't know what gland makes the estrogen?
No, it comes from the testosterone.
Well, it comes from so the testosterone's coming back.
Aromatization, aromatized.
Okay. So now it could well be that as this is coming back, you're actually getting an excess of estrogen, like we were talking about earlier on today, where somebody had, Don Rogers had a level of 22 for his estrogen, and that the estrogen testosterone is out of balance over the first 3 weeks. So you could take the two, and that's why you're getting the hot flashes. You don't have enough testosterone and you have too much estrogen. And I guess if you tested those, that's what we would know.
So it's so dysregulated that you could expect anything like this, because it's nothing sustained. It's like all over the place.
Yeah, I mean, I can't say that medically yes to that, but what I'm saying is that all bets are off because now everything's coming back, and it doesn't necessarily come back in the same ratio that it was before you started. And someone like a Belusic is going to be able to answer that for you and probably do the testing and tell you. Were your hot flashes out of alignment, Don Rogers, when you came off initially?
I have never experienced a hot flash.
Oh, okay.
The entire 2 years, I never had a hot flash.
Okay.
I was very lucky.
Okay. Well, there you go. So that didn't help us. Now, I mean, it helped you. It helped you, but it didn't help Dr. Jack. But I would definitely say that could well be that it's all out of alignment. It's all a little crazy. Len or John, I mean, what do you think about that theory?
I just don't know, Rick. Maybe John.
No, I don't either. It makes sense. We really need an endocrinologist.
Yeah. So Belusic was telling me when I was having some itching initially, he said to me, it's all absence of testosterone, your skin loses, your sweat glands aren't working well, everything gets very dry, and I do notice my skin's getting more moist. So, that may be coming back with that the secretion, sweat glands starting to operate again. It could be possible that that's all working to cause some, something going on with my sweat glands and sweating and really perspiring. I mean, like I hadn't done before. I mean, just it feels like my autonomic nervous system is going bonkers. It really feels, like almost neuroendocrine, but not a neuroendocrine cancer. Just some effect. It feels like it's my, autonomic nervous system is out of whack.
Well,
Right.
Jack, if you read my intro or a reminder, it may be helpful to take 2 placebo.
Hey, Glenn, do me a shove it up your ass. All right? I mean, you know, I'm trying to be serious with you guys, and you have some kind of bullshit like that. Take 2 placebo.
It worked with DMS.
Rick tells me that I'm definitely placebo. Come on. I wouldn't bring this up and waste your time unless I was curious whether or not you knew what could be going on. But obviously you don't. That's okay because I don't either.
Sorry, Jack. I really don't know.
All right.
Jack, didn't we discuss this last week about your testosterone not going back up very quickly? It was stocked around 50 or less than 50?
No. You have the wrong guy.
Oh. Who else was that then? 700. Right. It's still good.
Right, good enough. Thanks. I'll let you know.
Let's see. Larry, you've got your hand up. Larry, yes. Alaska.
On the hot flash thing, I suggest we take a lesson from postmenopausal women. And I'm going to suggest that having unstable gonadal hormones going up and down and going in crazy directions causes your endocrine system to raise your body temperature, open up blood vessels, close them down, and cause hot flashes. It's the instability rather than the levels. How's that for a theory?
That's what I said. Dysregulated, up and down. Menopausal, same thing, right. I agree with you, Larry. Oh, but there's no solution. That's just the way it is.
You wait it out.
I think that's very insightful because I think with endocrinology, it's just what you said, Larry. Sometimes it's not the level, it's the change in level. And even further than that, it's the rate of change in the level.
All right. Eric W., you are the last on my list. And then after Eric, if anyone else has any issues, you can bring it up.
Okay. So I got a couple things. So my last visit to my doctor, so she hinted, Dr. Marshall at John Hopkins hinted of she was thinking, she was hesitant or thought about at least giving me a holiday off the Extendi and Orgovix, but she says she didn't really want to do that because I wasn't on it for a year. But then she also alluded to of possibly continuing the medicine but not taking it every day. Is that like a normal process of maybe not taking the Extendia and Orgovix daily, and maybe some other interval of frequency? Anybody heard of anything like that?
Yeah, I've heard of guys taking hormonal medication 1 month on, 1 month off. It's not standard of practice. You won't find any clinical trials where they've done that, Eric, but bottom line is by doing things like that, if it controls your PSA, it's probably fine.
Okay. All right.
And if it improves your quality of life. Anybody else want to jump in?
Yeah. I was told when I started Orgovix that it has a 25-hour half-life, so it was very important to replenish it every 24 hours, regular basis, because once it drops, it stops the action. Now, the trials they used to justify the use of Orgovix as standard of care, they all took the same dosing, and there's been no indication that that it's dose proportional. That if you reduce the dose, at some point it's going to not work at all. We raise it up to a sufficient level, it works great. And that's where the medical science is right now, as it was explained to me by my doctors. So taking it every other day, probably not. Again, probably would be against medical advice. Now, taking it for a few months and then going off of it, that's called intermittent therapy, and that's something that the doctors are doing. But as far as day on, day off, I don't know of anyone doing that.
She didn't say what the frequency was, but I was under the impression that it was going to be an everyday thing for at least 2 years, and then get a holiday, then get back on it at some point in time. Because she said, you're going to have to take this for the rest of your life at some point, for some point in time. So that's what. Go ahead.
Eric, let me just understand. Is Dr. Handy Marshall suggesting that you, from what you understand, is she saying you take both medicines intermittently on a daily basis? So maybe you'll take them 2 days on, 3 days off, 2 days on, or is she taking one intermittently? Or I mean, what do you understand her advising you?
That was unclear because I was more taken back. I was like, oh, I didn't think that was like an option. So I did not get clarification on that. So I don't know. I was more under the impression that it would be like maybe take it for a couple months, then off. But I will have to get that clarification from her.
So I think that again, there's so many different options in the way that you could take a lower dose. That, well, Larry, you're shaking your head. You don't even know where I'm going on this, man.
Just lowering
you don't
the
know where
dose.
I'm going,
Yeah.
right?
Okay.
There's
Go
so
ahead.
many different ways in which you could take a lower dose. So you could take a lower dose by, you've been on for how many months now?
8.
18, did you say?
No, 8.
8. You've been on for 8. So, you could take a lower dose by going on an immediate full vacation, although that doesn't seem to make a lot of sense to me, and then stop for 3 months and then come back on, but that would be weird. You could take a lower dose by cutting out the enzalutamide and just doing the Orgovyx. You could take a different or a lower dose by cutting out the Orgovyx and just doing the enzalutamide. And you could take a lower dose by taking just a lower dosage each week, less of each week. Larry seems to think that the lower dosage doesn't work. I don't know enough to know, could you take it as a lower dosage? But I think you've got to go back to Dr. Handy Marshall and you've got to see what she's saying and come back. My own gut tells me, because everybody says this, everybody comes to us with this same discussion. You got to do the time before you start talking about coming off of it. Before we start, I mean, we've had so many guys, and especially the younger guys, and boy, I get it myself. Let's not even talk about changing the dosages for 18 months. And then let's talk about changing the dosages and how to change the dosage. So I think you've got to go to her, you've got to find out exactly what's on her mind, come back to us, and then we can kick it around. Go ahead, Larry.
Yeah, I was shaking my head vigorously as being against cutting the Orgovyx in half. Like cutting the pills in half or taking it every second day. Now, I am on my own clinical trial of 1. I stopped the Orgovyx and picked up estradiol against medical advice, and that's tantamount to what is being suggested here, cutting the Orgovyx dose in half. And you could do that. That would be your own medical trial of one patient. And you could do that and watch your PSA and your testosterone levels and see if they start to climb. So that would be an experiment. But if you don't want to be experimenting with your very own clinical trial, and get your doctor on board with this, that's the tricky thing to do. I chose to do it, but I'm not in a position to recommend other people do it with the Orgovix.
Did you know how
Well,
much estradiol patch to take?
I studied up on what Russell and Ockram and Langley and others were doing. I spoke with Dr. Montgomery at Fred Hutchinson Cancer Center. I read the studies by Garzotto down at the Oregon VA. And I decided that an estradiol level of around 200, 250 would probably be a good level to start at. And that seems to be working for, I got about name of 3 dozen guys who are using estradiol or want to. And I've been very successful, although I have to admit my estradiol levels have been a lot higher than my target level. And I'm trying to get them down, but they've been erratic. So it's been, my clinical trial has been a trial. But I'm working on it diligently, and I have been blessed with being able to get PSA and testosterone and estradiol levels on a weekly basis. So I am able to keep track of this very closely, and I'm intent on not hurting myself.
You
I
didn't
also have.
answer my question. You don't talked about blood levels. You didn't talk about how much of the patch, how many patches a week.
I started on 4 patches. The estradiol levels were so erratic, but I was taking Orgovix at the same time. I eventually switched to injections.
Oh.
So I'm using.
I don't, we've sort of diverted to Larry's managing his estradiol, and I want to go back to Eric. And then if we got time, we can
I didn't want to leave. I didn't want to leave Eric either, but we got off on that.
So,
but if Eric wants to do his own clinical trial,
so let me. So what I'm saying to Eric is this: we know that monotherapy, second-line anti-androgens work because we've seen it. It's all it's all anecdotal, but we've seen guys on monotherapy apalutamide, monotherapy enzalutamide, monotherapy abiraterone, and monotherapy darolutamide, and they've all managed their disease that way. So if you're on a second-line anti-androgen and you want to mess around with the Orgovix dosage, it's probably relatively safe to do. We can't say that medically, but we've seen guys who have managed to cut out their LHRH drug altogether and still manage. Now, is it protocol? No. Is it recommended by anybody? No. Are there doctors who will do it? Yes, there's loads of doctors that will do it. And, if Dr. Handy Marshall has the idea that you could do fine on monotherapy enzalutamide, you could go with that, Eric. And monotherapy enzalutamide might mean you can stop taking the Orgovix altogether. At the same time, we tend to have seen the best results from people who stuck out the initial type of treatment for at least 18 months. And when they came off too early, it didn't work so well. So we're not giving you medical advice, but we are saying qualify exactly what it is she wants to do. Be aware that you could do a monotherapy with an ARSI, but don't jump ship too quickly. As much as you want to do it, don't jump ship too quickly.
Gotcha. Okay, so that and then my other thing is diet. So I've gained about 15 pounds being on the drugs. So I work out. I try to eat right, but I am hungry all the time. I eat all the time.
Right.
God
So
dang.
right. So let me give you my 2 cents on this and explain it. And other people will have ideas. the problem is that your metabolism is slowing down as a result of being on the hormone therapy. And when your metabolism slows down, that's why you tend to be hungry. And that's why, for example, women going through menopause tend to put on weight because they want to eat all the time. The trick that I found, and it kind of worked for me, is if you're hungry all the time, eat food that is not going to put weight on, like carrots or celery or vegetables. Is it as satisfying as putting a cookie in your mouth? No.
No.
Is it going to satisfy that hunger and you keep a whole bunch of celery sticks around and a whole bunch of carrot sticks or cucumber sticks? Yeah. It's not as good, but it does work, because I can tell you that from my own experience. So that's what I would do. Jim, you have your hand up on this.
I'm in here. Yes. The thing I do is to make homemade chicken broth. And provided I get a case of the munchies, I will heat some up and slowly sip it. And it can take me half an hour to do a mug, and it kind of calms down and with the cravings. But I never eat something after 6 o'clock at night. No food, only drink. Of course, then you have to get up to go to the bathroom, but that's okay. And just eat non-fattening foods if you can. Well, occasionally you can cheat, but just watch what you eat. Of course, you don't eat it. You watch. No. You are very selective. Stay away from the chips and the pizza and the pastas and all of that stuff. So.
Jack, you're up.
Yeah. Just wanted to mention the hyper eating and the hunger, how to deal with that. You got to understand, you get a little pre-diabetic. Your sugar metabolism is a little out of whack from the Orgovyx, and you have to deal with it by, finding a way of lowering your blood sugar. I recommend, if you want to take the supplement, berberine, 500 milligrams twice a day. That would help. I took metformin for the first time in my life, 500 milligrams twice a day. It helped. Curbs your appetite, keeps keeps you from craving, some of the sugar and the cookies and the ice cream and stuff. And it helps you stabilize your weight. I put on weight, but I didn't put on all that much, because I think the metformin and the berberine helped.
What was the berberine?
Yeah, BERBERBIME. It's a supplement you can buy, and it's very good. I've been taking it for quite a while.
And what does that do, Jack? The berberine?
It drops your sugar, just like metformin. It drops your blood sugar.
Okay. Larry.
I was wondering what your exercise protocol is, and an exercise coach might give you some guidance on how to exercise to lower your blood sugars and burn off fats rather than just building muscle.
Yeah, so my exercise thing is pretty good. So I do at least 45 minutes every day. Since I've been on medicine, I used to do, like, walk 5 minutes, jog 5 minutes, walk 5 minutes. But since I've been on the medicine, I walk 10 minutes, jog 3 minutes. So I had to kind of reduce that a little, but and then I also lift weights at least 3 times a week. So I kind of stay active. It's better when I'm in soccer season, because I'm on the field and running around, not thinking about food and stuff like that. But during the off season, things like that, it kind of gets out of whack.
That sounds optimal.
Yeah.
Excellent.
So,
how old are you, Eric?
I am 53.
Sounds like it. Okay.
I believe muscle tissue burns calories faster than fat. Am I right, guys? So,
Glucose.
yeah, so building up muscle, Eric, might help lose some weight.
Gotcha. Yep.
Yeah, as much as possible. You're a young guy, you can still lift a lot of weights.
Yep. Gotcha.
Keep your bone density up too.
What was that?
Keep your bone density up.
Oh yeah, sure. Oh boy, you guys don't want to quit, huh? All right, Graham, go ahead.
Unmute, Graham. Unmute. You're still muted. You need to click the little microphone if you can.
Okay, there we go.
There
All right.
you go.
Okay. Yeah, you asked what technique machine they used for my pelvic radiation. It was an Electa Versa HD, and the pelvic area technique was a TX Linac VMAT 594.
VMAT is IMRT.
Okay.
I'm pretty sure it's exclusively IMRT. I could be wrong.
Yeah. But that still doesn't answer the question of whether they did the entire side to side of the
Right.
pelvic. Yeah.
Right. Yeah, you have to ask your doctors, your radiation oncologist, what exactly are they radiating?
Yeah, and exactly, and what dosage, how many sessions, and what dosages, and if they are also focusing on your rib spot, that should be separate. Don't keep that as a separate identity.
Yeah, they are giving me the dosages. I have that. Means nothing to me.
What's do they give you the number of gray?
CGYs?
Centigrays. Okay, what is that?
Well, each one is looks like the most recent one was 275. And for 3 of 20 fractions, it says 825.
So divide that by 10, and those are your grays. I don't know.
Three fractions of 8 grays. That sounds like that might be to the rib. I don't know.
Yeah, this is the rib. Yeah, that's the rib. Oh, no, that was the pelvis. Sorry. Yeah, that's the pelvis. It says 825 CGY / 5500 CGY. 3 of 20 fractions. That's the total given so far. That was after 3 sessions. So each session, well, that session was 275 CGY.
Okay. Jim, you had your hand up or you took it down?
Well, I was about to say about the weight for me every morning. I jump on the scale. I want to see if I'm going up, down, or stable, because it then gives me the idea of what I have to do that day.
Jim, do you divide it by anything?
A factor.
Sorry, I couldn't resist. I couldn't resist. You know, we're talking about Graham about dividing by tens and multiplying by tens. I don't know centigrades. If you came back, Graham, because I don't want to leave you hanging there. I guess that
one gray is equal to 100 centigrades.
1 gray is 100 centigrades. So,
yeah.
What we're sort of wondering is how many grays are you getting per session, and where are they directing that? And that's really, so maybe next week you can come back and tell us, you can sort that out in also with the doc and come back and tell us, or the doctor's assistant.
How many grays per session and where they're directed?
Yeah, how many grays per session? What the total plan is? How many grays are they going to give you, and where are they they're going to give it to you. I think that if you're talking about the centigrades, we can manage to. Hopefully, Len will be here because he can divide by 100 and multiply by 100.
Okay, so CGY is metric, is it? Or something?
Well, yeah, centi as in 100. So what in this case it's actually 1/100th. One centigram is 1/100th of a gray. I'm sorry. So to convert your centigrade to gray, you multiply by 100. So 1 centigrade. Wait a minute. The other way around. Jim, help me. So 1 gray is equal to 100 centigrade. There we go. By the way, Jim redeemed himself. He put in the formula for converting millimoles to nanograms for testosterone. So I think we have to cut him some slack.
Okay,
Not
we'll
me.
cut you slack.
It was not me. I have to admit that it was somebody else. I don't know who it was.
It was Dr. John.
A calculator. I found a calculator and just plugged it in.
Okay.
Oh, okay.
Okay, to clarify for Graham, 100 centigrades is 1 gray, and we talk here in grays. Okay, so you can figure it out from there.
Yeah.
And
all right.
So I think we're going to close it out, Rick. Yeah.
Can we go home, gents? Is it okay for us to go home and eat?
Go get some sleep.
Get some sleep. Get some dinner. Get anything. All right, gents.
Happy Passover, happy Easter, and what else? Happy birthday to Alexa.
All right.
Good night.
Great session.
Everyone. Good night.
Have a good night.